the Precious PAH is actually an acronym. This is a 10-year-old study. This was initially presented in IHJ in 2014, and we have gone from analysis. This is for the CHD PAH. We have acronymized the word Precious from the preoperative cardiac catheterization in predicting outcomes of surgery in CHD with PAH. That is the PRECIOUS PAH study. So we know that PAH can be hyperkinetic, that is flow related, or it can be due to lung changes. It can generally be hyperkinetic in the early months of life, and once obliterative changes develop, there can be lung changes develop. Then it can actually go towards obstructive PH or even Eisenmenger syndrome if there's irreversible changes. This we have got a lot of studies actually from apex centers, including from Jaydeva in India, which got an award, where they have studied the post-operative course of patients in CHD PAH. We have generally defined operability in CHD PAH as being tested on oral vasodilators, and most studies which are done generally in India after a trial of oral vasodilators. 3 or 4 only have been published, one from AIIMS, one from Jaydeva. We have used oxygen as the most commonly used pulmonary vasodilator. Nitric oxide is not generally used, and our general definition of reversibility for CHD PAH, which is most prevalent, is that there should be a drop of by mean of PA mean of more than 10 and to a level below 40 without a change in the systemic status, though it was done in an older era with CCB nifedipine. So the cath is done generally. We watch 3 parameters, that is PA pressure fall, PA SATs improvement, and an increase in the
Prayaag, I'm sorry, can you just show the objective, please? Show the objective.
AIIMS, sir. So, sir, actually, why I give this background is because we have done this study.
Let me understand the objective.
Right, sir.
These 5 objectives you have, is it?
Yes, sir. To see the propensity of certain lesions, which lesions cause CHD PAH, to understand the behavior of CHD PAH in hospital and short term, that is 1 year, and long term outcomes, to find out the predictors of residual PAH, to understand the behavior of how oximetry and pressure cath data
residual PAH after what? After surgery?
Surgery, sir.
Okay.
To understand the behavior of how oximetry and pressure cath data help us to decide the post-op course, that is, who will do worse or who will do better, and to understand whether there is influence of factors such as low birth weight, prematurity, sildenafil naive state in the post-operative course.
Go ahead.
So we have actually grouped surgeries as per the international classification, in which they say it is group 1 complex CHD, group 2 significant CHD, group 3 minor CHD. This is from ACC AHA classification, in which most of our patients are in group 2 and group 3 for this, group 2 mainly. And then other CHDs as dysrhythmias and cardiomyopathies, secondary dextrocardia, levocardia. This was all a part which has continued from the earlier pressure study done in 2014. We have also gone ahead with the Ratches 1 score. Ratches 1 score essentially is a risk adjustment for congenital heart disease, in which it goes from grade 1 to grade 6 in the increasing level of complexity. In our study, the independent variables was gestational age of the mother at delivery for prematurity, birth weight again for prematurity, if there were any extracardiac malformations, type of delivery, type of CHD, treatments for CHD PH, cath study parameters, need for mechanical ventilation in the child, and whether the child required antibiotics and vasoactive drugs. And the dependent variable was residual pH after surgery at 1 year till the last available follow-up with a 5.4 years mean. This is statistics done, as I mentioned, on SPSS version 26. We have taken originally 155 patients in the original study, sir, up to 2014, and that has swelled to 405 over the last 10 years. Again, there was sequential recruitment. So the initial study was 5 to 12. We have continued till 2017, and then we have followed this up to 2022. All patients underwent a standard cath procedure for CHD PAH, which was done with 100% oxygen for 10 minutes before measuring all the parameters again. Of total number of patients, 65% had been on a 3-month course of oral sildenafil. We have calculated all the cath data, which we usually do: PVR, PVRI, PVR by SVR, and then QP by QS. LV angioautogram was done. We have defined ICU stay as long if it is more than 5 days, and very long if it is more than 2 weeks. As per the anesthesia colleagues, the length of intubation was considered as more if it is extended more than 3 days, or the patient required reintubation within 12 hours of an extubation. So for the original study, the primary endpoint was at 1 year, if the patient had residual post-op pH, if there was longer need of invasive ventilation, if there was a need for post-op milrinone, nitric oxide or inhaled NTG, reintubation for pH crisis, or if there was cardiac mortality. So in our study now, for the current study, till we have got 5.4 years, as I said, till the last available, we have seen all these are the parameters, that is cardiac mortality, residual pH, need to continue oral vasodilator more than 1 year because of the residual pH, and if the patient had recurrent heart failure admission, and the Ross grade. This is the flow of the study. So we have seen the demographic patients in those who had residual pH, arm A versus those who did not have. To see the predictors, we have done again a univariate and a multivariate analysis in the determinant cohort, applied ML, and then created a risk model for that. We have seen it in three cut points in hospital mortality, PH need for reintubation, as I mentioned earlier, 1 year after surgery and 5 years after surgery. In the entire cohort, the age was mean of 9.8 years with a slightly male dominance. We had a 13.5% prematurity rate. Syndromic children were 5.5. Extra cardiac issues were seen in about 27% of cases. The commonest symptom with the child got admitted was like respiratory infection, recurrent respiratory infections with poor weight gain. Like as I had mentioned, 65% were on oral vasodilator therapy, and ROS grade 3 was more than in 45.5%. In terms of the frequency, what did we have? The large VHD pH was the most common. Then coming down to 120, PDA pH was the most common. Second was large VHD pH with 73, and ostium secundum AHD was 69, split as 25 of ostium secundum, 19 ostium primum, and 25 sinus venosus AHDs. Others were also as mentioned here. We had a kind of a combination lesion, VHD PDA in 19, AP window in 19, and the others as I mentioned, complete AV canal in 17 and CoA in 11. In the logistic regression analysis, sir, we have seen that actually it shows both the univariate and the multivariate analysis. Again, sir, this is, sorry, it was AUROC of 0.66. This is the multivariate analysis in which age less than 1 year at surgery or more than 7 years at surgery, both were likely to portend towards like increased residual PAH. Weight at surgery less than 3 kilos. Type of CHD, I told you that if it is 2, that is grade 2 more than grade 3. Grade 1 were not too many, sir. We have about 80% which are grade 2 only. So it was more likely to portend towards a residual PAH. ROS grade 3 was more in those patients. Pre-cath, like vasodilator therapy was actually higher. Past PA band was done, but it was not significantly different. Syndromic child was more. Children had more residual PAH. Extracardiac malformations were higher. Prematurity also ranked more. The age of the mother more than 40 was not significantly different, but it was higher in the patient without reaching the p-value. I'll say that this is my ROC, sir. This is 0.658 again. We have seen that there are if you see in terms of an ML analysis, we have seen all the factors against each other. This is again putting all the factors. So what we got is that TAPVC PAH, truncus PAH were quite high. PVR SVRI of more than 0.27. If the PAED drop was less than 20%, if the sildenafil naive patient was more likely to get weight less than 3 kilos. Post-op pneumonia, if the patient had, syndromic children were more likely to get, prematurity was more likely to get. Can I go a little ahead, sir? Because can I take some time? Sorry, sir. So then this is the random forest plot. Again, it shows that in terms of the severity, truncus TAPVH, again, this is a sharp analysis which tells us how much strong a particular predictor is if it is red, and if it is not there, how much negative. If it is not there, then like how strongly negative it is. So if we had a truncus or a TAPVC PAH or a PAEDP, PVRI by SVRI of less than 0.15 actually predictive. PAEDP drop of more than 30% was actually predictive positively. That is, they were not having residual PAH, minus 0.73. PA mean drop more than 20% was again protective. PA SATs improving was protective. Syndromic child was here 0.43. If it was not a syndromic child, if the weight was more than 7 kilo, less than 3 kilos, sildenafil been given for 3 months was again protective. Age more than 1 year was again positively, like they had more residual pH. Prematurity had more residual pH, and weight less than 7 kilos versus more than 7 kilo was again actually protective. So the strength of predictors is this, sir. In terms of the the positivity down. So this is the weightage that we got. So the strongest predictor was on cath. If it drops more than 20%, they do the best. I mean, they have residual. If the drop is more than 20%, they do the best. If it is less than 20%, they are more likely to have residual pH. Weight less than 3 is more residual, like more pH. PVR, SVRI more than 0.27. These three can be either clinically diagnosed or on cath. TAPVC pH, truncus pH went down. It was 3, but it's the same. It's the same weightage. It's all 3 down. Then sildenafil 9 was again equally predictive, that is 3. Syndromic children, complex surgery, but if it is 2 more than 3, 1 or 2 more than 3, age less than 1 year versus age more than 7 years, all have been seen to be predictive. PDA, PH, the one thing that we got, sir, is that if we staged it, we had put a PDA device and then sent for surgery, it was actually predictive. If we sent for surgery within 6 months. In terms of accuracy, sir, it was again 0.85 accurate. So there was hardly a difference between the two, P 0.85. And they all did worse at 5 years. This is a 5 year data. We had it with a significant attrition, sir. I plead guilty for that, 42% attrition. But then whatever we got, they've all done worse in terms of Ross grade, recurrent heart failure, oral vasodilator need, continuing shortness of breath, and having mortality. So I'll conclude saying that PAEDP drop less than 20%, prematurity, syndromic children, weight less than 3, or age more than 7 years are all more likely to be, and of course, truncal and TPS etiology are more likely to portend to more of like residual PH. We have given these children a trial of 3 to 4 months of sildenafil. It has actually helped them. Even that much trial is enough to give a better result.